Hey guys, hope I'm audible and visible. A very good evening, everyone. Sorry for the initial 30 seconds that my audio is not audible. Welcome back once again. So we are starting the INICET PYQ series. I'll start with pathology and you'll have a series of lectures primarily for someone who is wanting to give INICET but thinks that that's not my main goal. NEET PG is my main goal, but I'm not able finding enough time to compile the important INICET topics. That's where we're going to see here, right? Hope I'm audible, Pandit, now. Okay, perfect. Yeah, thank you guys. Okay, so what I'm going to do is I have collected top questions from the recent INICET exams, um, 25 November, May, and then 24 November, May. I'm going to show you a few questions. We are going to discuss, analyze what is the right answer and why the other options are wrong, right? Primarily, the goal is to increase the problem solving capacity rather than reviewing the topic. We'll have a marathon series maybe to review the topic at a go, but it's primarily to understand and to solve the questions. Fine. So I want answers from you guys. So everyone, I want answers from you. So I'll display a question. Simple questions. These are questions which came in the real exam. So let's see how many of you can answer it. This also will give you a confidence that the exam is not that difficult. What's the right answer? Bojack, I'm just taken a bits and pieces of multiple places. So we'll have a cumulative assessment of most of them. Answer, which of the following is not associated with granulosa cell tumors, obviously of the ovary? I want answers. See, it's okay if you go wrong. It's fine if you go wrong. Sanvi started with option 4. It looks like a pretty easy question, but if you read one and the other option, it might look overlapped, right? So if you don't have an in-depth understanding of CA 125, that is going to be a bigger problem. Generally, students, what they say is CA 125 ovarian tumors. That's not right. CA 125 will be elevated only in epithelial tumors of ovary, not in every other tumor. Please do remember, this is only for epithelial ovarian tumors. Again, it's not a marker which is very specific for tumors alone. Even conditions like endometriosis might have a problem, right? So again, INICET tests your core concepts. It's not about how much you know, it's about how correctly and how much depth you know is what INICET generally tests. And most of the basic sciences has been test 60-40 ratio, primarily because of the reason basic sciences forms the concept in general, right? So if you take granulosa cell tumor, I'm sure most of you know the granulosa cell tumor. If I ask you a question like the Karl Exner body, everyone will tell. Inhibin positivity, everyone will tell. Maybe what must have stumped you is the sex cord stromal origin. Most of you will know that granulosa cell tumor is from the sex cord stromal origin only. It's classified under sex cord ovarian tumors, right? And CA125, like I said, and also like Sanvi said, it's a marker of epithelial tumor of ovary. Your serous cystadenocarcinoma, mucinous cystadenocarcinoma, clear cell carcinoma of ovary, Brennus, all the tumors which are from epithelial origin will have an elevated CA125 and not the sex cord stromal tumor or even the fibroblastic tumor. Anything apart from that, your germ cell tumors, it will not be elevated. Only in epithelial tumors of ovary, it will be elevated, right? So let's see if you can answer this simple question. In case of teratoma, do you think CA125 will be very much elevated? Yes, no, maybe. Teratoma comes under germ cell tumor of ovary. Dysgerminoma comes under germ cell tumor of ovary. It is not a classical marker. Will it be elevated? Yes, it might be elevated. Can I use it as a marker? No. Generally, CA125 is used as an epithelial tumor marker, not germ cell, not sex cord stromal tumors, not any other metastasis or any of them, right? Since we are in ovarian tumors, I'm going to ask you few one-liners. Let's see if you can answer this question, right? Tell me what's a name for the lesion what we will have for metastasis to ovary. As a first question, I'll keep on asking a few questions with relevant to ovarian tumor histopathology. Let's see if you guys can answer that. Tell me one site for teratoma which is not testis or ovary. Testis or ovary, I'm sure you know the answer. Site of teratoma which is not seen in testis or ovary. Okay. I want answers. Great. If you tell the wrong answer, I'll tell it's wrong. If it's right answer, amazing, right? Tell me at least one marker or one IHC marker for dysgerminoma. Okay. These are pointers which has been asked previously in the INICET exam. I hope this will help you as a final quick go through. Tell me whether beta HCG will be elevated in dysgerminoma or not. If so, why? If not, also why? Great, guys. The first answer is Krukenberg. Let's answer time. It's Krukenberg for sure. I am not sure why you didn't answer the second question. The second question is very simple. If you've seen pediatrics OP guide textbook, there'll be a kid lying down like this and a huge mass in the back, right? Sacrococcygeal teratoma, it's possible. Mediastinal teratoma is possible. Teratoma in the CNS is possible, right? So you'll have mediastinal, you have sacrococcygeal, okay, and also in the CNS. In the midline, most of them it'll have it, right? One marker for dysgerminoma, great. HCG is not actually a marker, I would say, Kirti. PLAP, okay-ish. LDH again is not a marker per se. LDH is going to tell me about the tumor. See, when I say marker for dysgerminoma, I want specific markers, right? CD117 is a decent marker for dysgerminoma, right? 117. Your c-kit of CD117. Then your OCT3/4, amazing marker. NANOG, amazing marker. SAL4. See, these are the recent markers and these are specific for dysgerminoma or germ cell tumor, right? LDH, the commonly confused one. LDH is not a marker for any particular tumor. Bigger the masses, bigger the LDH will be. More cells die, more LDH will be. Even in hemolytic anemia, LDH is elevated, right? It's very, 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 very non-specific. One thing it will tell me is if LDH is very high, I can predict that the tumor is very big, that's all. Hlichdoi. HCG is not elevated in dysgerminoma, right? That is an MCQ point. Unfortunately, that has been made as a mainstream point. Seminoma, dysgerminoma, 10-15% of them have syncytial trophoblastic like cells. In those 10-15% of them, beta HCG will be elevated because beta HCG is a marker of placental tumors or trophoblastic tumors, right? Yes, it will be elevated in 10 to 15% of dysgerminomas because of syncytiotrophoblastic like element. But if I am going to diagnose a dysgerminoma or a seminoma, I am not going to rely on beta HCG. Beta HCG is a marker of which tumor? Choriocarcinoma. Yes. Okay. For choriocarcinoma, it's an absolute marker. Hydatidiform mole, an absolute marker. Wherever trophoblast is involved, it's a good marker. For dysgerminoma and seminoma, 10 to 15%, it's positive, right? Perfect. Let's go to the next question. Let's see if you guys can answer this. Simple one. A, B, C, D, 1, 2, 3, 4, whatever you want to answer them. But I want you guys to answer. It's okay you make a mistake. These are very, very good scenario-based questions. This is how in real life you will be seeing patients with most of the information available. Okay, option with C, macrophage, Sanvi, others. Come on, guys, you can answer it. See, let's try to eliminate the options, right? Most of you went for serous carcinoma. This PYQ, when we discussed, when the recall came, most of them said mucinous acidinoma. Very rarely people went for serous carcinoma. And there was a huge confusion amongst your seniors also when they gave the exam. The reason of the confusion is not able to correlate findings, right? Bilaterality will not help me in telling benign or malignant. Multiloculated will not help me in telling benign or malignant. This is very, very important. The moment you start seeing solid component in a cystic tumor, think of a malignancy. That's the first clue. Second, image shows omental caking. There's nothing but clue for secondary deposits, metastatic deposits. CA125 will be elevated in both mucinous acidinoma as well as serous carcinoma, right? That is not a finding for me, it will help. But when I say CA125 above 1000, right, that's kind of a clue. Anywhere when it says any tumor marker of above 1000, it's mostly cancerous because tumor marker are never diagnostic, they are an adjuvant to diagnosis, right? They are adjuvant to diagnosis. Cystadenoma is a benign tumor. CA125 might hold true, but solid areas and omental caking, I will not be more aligned towards. So it's not right answer. Granulosa cell tumor CA125 will not be elevated. Endometriosis or endometrioma CA125 will not be elevated, right? But so the best answer is going to be serous carcinoma which fits into the clinical picture of malignancy. That is very, very important for you to understand, right? Now, just one simple question. Can anyone tell me what is the mutation which is associated with serous carcinoma? See, because these days, when you come to diagnostic pathology, most of the things are driven by mutations for serous carcinomas. I'll also add to that few more things as well. Endometrial adenocarcinoma, routine endometrial adenocarcinoma. What's the mutation? Anyone which comes to your mind. See, one clue, if you don't know something and if you feel it's an aggressive tumor, always take a bit of TP53. P53 is something which is common in most of the aggressive cancers. Serous carcinoma is an aggressive cancer. P53 is going to be mutated. Endometrial adenocarcinoma, especially type 1, endometrial adenocarcinoma. Type 2 is going to be P53. Type 1 endometrial adenocarcinoma is going to be P10. This is one of the commonest mutations seen in endometrial adenocarcinoma. Do remember them. I want you guys to think about that as well, right? Just one more thing, since we are in the female genital tract, tell me any one marker for HPV. See, we know that about HPV, about your 16, 18, 13, 33, 35, everything. We know about E6, E7 proteins, right? But what has not been touched till now is what is the marker of HPV? Let's say I have a cervical carcinoma patient. I have to prove this patient cancer is due to HPV or an adenocarcinoma of cervix due to HPV. How will I prove it, right? There's a marker for HPV. Remember it, it is P16. Whenever P16 is positive, wherever it is, right? Be it in the oral cavity, be it in the larynx, because the HPV can cause tumors in the oral cavity and larynx as well. Be it in your external genitalia, if P16 is positive, it is a surrogate marker of HPV. Do remember them, don't miss them, right? And there are few proteins with HPV. Tell me what is the function of these proteins? All these three proteins has been asked in INICET before. E6, E7 are proteins which are going to help in pathogenesis, reduces or destroys P53, reduces or destroys retinoblastoma. This is a protein which will be mostly seen in the vaccines of HPV, right? L1 is a protein which will mostly be seen in the vaccines of HPV. Okay, great, great. Okay, let's see the next answer. Simple question. What's the answer? Amazing videos goes with follicular. Patient presents multiple punched out lytic lesion in the skull. Which thyroid malignancy is most likely? See, follicular again. It's a very simple, fairly simple question, right? So I will discuss about two tangents here. See, like I said in the start, the class is about approach to an MCQ. That's all, right? Now we'll have the same punched out lesions in the skull. Okay, though it's kind of radiological, but I want you to understand it's never radiology or pathology or medicine or surgery. It's about the patients. That's all, right? Okay, punched out lesions in the skull. If the question says it's a child, what will be a diagnosis? And if the question says along with the punched out lytic lesions in the skull, the patient also has anemia, what will be a diagnosis? What will be a first thought? And the patient says the history says there's a thyroid mass. Thyroid mass, you told me the answer. I'm going to go with definitely follicular. Follicular can cause pulsatile bony secondaries. Very, very characteristic finding of follicular tumors. Okay. Great, great, great. The first thought, if the child punch out lesion in the skull, I'll look for LCH. I'll think of LCH. If it's anemia and multiple punch out lesions in the skull, that's classical for a myeloma. Okay. Now, second, since we are in pathology, we'll have to talk about pathological impact also, right? Tell me, what will you see in the microscopy of LCH? 1. What will be the immunohistochemistry which comes to mind with respect to LCH? 2. Microscopy, one characteristic find for LCH. LCH is a Langerhans cell histiocytosis. Please remember, your tennis racket appearance is not going to be in light microscopy. I know, amazing video. Some of one will say Berber granule. Berber granule is an electron microscopic finding, not a light microscopic finding. I'll write that also for your ease. Because Berber granule is always in our head, right? Right from day one of when we started reading LCH, Berber granules are always there. What is in light microscopy? Eosinophils plus coffee bean nuclei. Very, very, very characteristic. Lots of eosinophils plus coffee bean nuclei is characteristic of an LCH. Marker? Great click doi. Some homobody is not a finding seen in LCH. Any one marker. One marker is enough for me. There are lots of marker. Langerhans is an amazing marker. Langerhans histiocytosis. In addition to that, CD1A. Okay. Langerhans, CD1A. Langerhans other name is CD201, right? Langerhans or CD1A, both of them are decent markers. CD1A, which is something which is commonly done. Langerhans is much more specific marker. Fine. Okay. Myeloma. Microscopy, I'm not going to talk about myeloma because myeloma are diagnosed not about microscopy. Myeloma are diagnosed based on criteria, right? I'm going to tell you two criteria. You're going to tell me what's the second criteria. The first one is CRAB. I'm great, Tushar. CRAB criteria is you know what is CRAB criteria? Your renal dysfunction, your hypercalcemia, anemia, and bony lytic lesion. That was the oldest criteria. The recent criteria and is almost allowed seen anywhere is SLIM criteria. What does SLIM stand for? CRAB is not used anywhere. Right from 2014, CRAB is not used. We are in 2026. There is no use of learning CRAB these days, but still there are places where people crib on CRAB. SLIM is the one which is being used. That is your bone marrow plasma cells of more than 60%. One is enough for me to call it myeloma, right? Perfect. Then L for your light chain ratio. Okay. The involved to uninvolved light chain ratio of more than 100. Okay. Which means the involved chain is 100 times more than uninvolved chain. I'll call it definitely a myeloma. Third is in MRI, you'll have more than one focal lesions. More than one focal lesions in MRI, that's also diagnostic of myeloma. Any one of this is enough for me to call myeloma, not everything, not two of three. One of these is enough to call it myeloma, right? Since we are in IHC, can anyone tell me at least one marker for plasma cell? One marker for plasma cell. Absolutely right. CD38, CD138, a very old AIIMS MCQ. If they ask it back again, Syndican is the other name for CD138, right? Perfect, great, done, super. Now let's go back to the question. Question is simple. It's a follicular carcinoma of thyroid, which will have bony lytic lesions, right? Great. Next question. Tell me what's the right answer. A simple one. I'm sure you guys will answer it. Cyclin D1 is more of a prognostic marker. Kitna? Diagnostic 38, 138 should be enough. 56 is also a prognostic marker. Most common inherited bleeding disorder. Amazing video. Ashutosh goes with C. Amazing video goes with A. Mohan Kalyan goes with A. Macrophage goes with von Willebrand. Why is there a confusion? It is undoubtedly von Willebrand disorder. Hemophilia is not that common. Von Willebrand is way common than hemophilia, right? Okay. Please remember, it's von Willebrand disorder, which is commoner than hemophilia. There are few things which is must know for von Willebrand, not for an MCQ point of view. Since you are going to be practicing physicians in the future, it's very, very important to know von Willebrand. Some of us might still have von Willebrand. It's a very common disease, but very underplayed disease, right? So von Willebrand disease, the most common inheritance is autosomal dominant. Okay. There are two ways by which I can divide von Willebrand. One is a quantitative defect, where the amount of von Willebrand will be less. Okay. Quantity. Type A will have lower von Willebrand. Type C will have almost zero von Willebrand, which means it reacts like your hemophilia, type C von Willebrand, right? Next is quality, where the number of amount, like the units of von Willebrand will be normal, but the function, it might not bind with the platelet, it might not bind with endothelium, something abnormal there, that's quality, right? Overall, most common is autosomal dominant, and the most common subtype is type A, that is also autosomal dominant, right? So in an autosomal dominant condition, I'll have one allele mutation. The second one allele, I'm not going to have it. Fine. Okay. So only one mutation, second one is normal, which means 50% of the von Willebrand factor is already produced. So the presenting feature is bleeding after trauma. Normally they might not bleed. Once there is severe trauma, they bleed. And one of the genders has trauma every month. The most common presenting feature is menorrhagia. It's almost always missed. If you're going to become a gynecologist in future, if you see a patient of menorrhagia, obviously the first thing is rule out local causes. Genitourinary based causes, rule it out, right? Hormonal causes, rule it out. Nothing is there, please do a ristocetin binding assay. It's positive, it's very, very important. This you should never forget. If it's von Willebrand, why I'm emphasizing so much is this lady can become pregnant in some time. And when the baby is delivered, postpartum bleeding, do you think with von Willebrand disorder we'll be able to stop it? No. This is important. So please investigate once you rule out every local hormonal causes, because this patient might have a very terrible PPH. You cannot stop with compression. You cannot stop with suturing because the problem is not in the uterus. The tonicity drugs will not help it. The problem is in the blood, von Willebrand, right? That time, how do you treat? Treatment is possible because type A is not absent von Willebrand, it is reduced von Willebrand. We give a drug, I want you guys to tell the drug, that will increase the release of von Willebrand factor from endothelium. Okay, that's one of the storage space of von Willebrand factor. It will release them from endothelium. What's the drug? The drug is given intranasally. That is the only reason von Willebrand disorder should be known for every undergraduate. Perfect, desmopressin. Because at some point of time, diagnosing this will save a patient's life, right? That's our major goal. Everything else will automatically come in between, fine? Hemophilia is not a common finding. Hemophilia is something which is often discussed in an exam. Okay, hemoarthrosis, a classical finding of hemophilia, fine? Perfect. Since we are in hemophilia, I want you to tell this as well. Okay, there's a patient, let's say you're doing a coagulation study. Before even going to coagulation study, can anyone tell me what is the anticoagulant which is used for coagulation study? Or tell me what is the vacutainer in which I can do the PT-APTT? Which vacutainer? Which vacutainer? We use trisodium citrate, right? Use citrated blood is the anticoagulant and the vacutainer is light blue vacutainer. This is the only vacutainer in which PT-APTT should be done. If it is not done in this vacutainer, the results by default will be wrong. Please remember this, right? It's light blue vacutainer. I have to be citrated blood only, right? So now let's say PT is normal and the question says APTT is elevated, right? And you have ruled out von Willebrand disease. It is not von Willebrand disorder. What's the next step? This came once in an INI exam. What's the next step? PT normal for a patient. APTT is elevated. Von Willebrand disease is ruled out. What's the next step? The next step, will you diagnose hemophilia? No. What do you think? Can you diagnose hemophilia? No, I cannot diagnose hemophilia. What should I do? I should do a step test called as mixing study. This is very, very important. If there is an isolated elevation of APTT, the next step is mixing study. INICET loves the next step. A patient with spherocytic anemia, the next step is do Coombs test, right? That's where the next step comes. What's the approach? Approach is what INICET tests a lot. We do something called a mixing study. Mixing study later will tell me if APTT gets normalized after mixing study, my diagnosis is hemophilia. If APTT is still being elevated after mixing study, my diagnosis is inhibitors of factor. Inhibitors of clotting factor is nothing but an autoimmune disorder. Okay, just remember this. That's more than enough. I have explained in detail in the lectures. If you have a doubt, go and have a look. What is mixing study and how do I do it? Fine. Okay, there's a change here. That's why I included this question. What do you think is the answer? Whatever comes to your mind, what do you think is the answer? Caspase 1 is involved in which of the process? Definitely not apoptosis, necroptosis, ferroptosis, pyroptosis. This is simple one, right? I thought you guys will ace this. The answer is simple one. Great. It is pyroptosis, not ferroptosis, right? Ferroptosis does not have caspase. It's like necrosis, but iron mediated. That's what ferroptosis is. Necroptosis is again caspase independence cell death. There's no caspase there. We have a complex called as an RIP complex, rest in peace complex, right? RIP complex is the one via which your necroptosis acts. Apoptosis, yes, we have caspase 8 and 10 for extrinsic pathway of activation, caspase 9 for intrinsic pathway of activation, right? Caspase 3 and 6 for your execution phase. Okay, these are the numbered caspases, right? Perfect. Till the last edition of Robbins, it was caspase 1 which was involved in the pyroptosis mechanism, right? Now also caspase 1 is involved in the pyroptosis mechanism, but Robbins 11th edition has introduced a new method of pyroptosis in addition to the existing method. So what Robbins says that is, if you're someone who's preparing for the exam, this might come as an update. Please have a look. There are two pathways for pyroptosis. One is canonical, one is non-canonical pathway, where you have your DAMPs, damage associated molecular pattern, or pathogen associated molecular pattern binding to a receptor which activates your inflammasome. Okay, the inflammasome is the one which is going to activate your caspase 1. The caspase 1 here is going to activate the pro interleukin beta to an active interleukin 1, interleukin 1 beta to an active interleukin 1. This causes the fever, this causes everything, this causes pyroptosis. Okay, this was the original one. If you remember Robbins used to say that caspase 1, 4 or 5. They're not clear what happened. Now it is very clear that caspase 1 is involved in this step. At the same time, there's one more step. We call it, in most of the bacterial cell wall as lipopolysaccharide. The lipopolysaccharide can directly trigger caspases 4 and 5. It's direct. There is no inflammasome pathway here. It's directly trigger caspase 4 and 5. Absolutely right, Brahma Reddy. Okay. Directly trigger caspase 4 and 5. Once it directly triggers caspase 4 and 5, that activates a protein called as gasdermin D. There are multiple gasdermin, but gasdermin D is very important. There's a new addition in Robbins 11th edition. Please do remember that again causes cell membrane damage. That again causes your pyroptosis. Fine. That's the update there in the new edition. If you are preparing for NST, this might come handy if they ask in Robbins 11th update. Fine. There are two pathways in pyroptosis. Previously, we had only this. Robbins used to add in brackets 1 along with 4 and 5. Now 4 and 5 has a different mechanism of action as opposed to caspase 1. But both are going to end up in having pyroptosis only, right? Perfect. Next. Great dialogue. Erythropoietin is useful in which of the type of anemia? Nutritional, CKD-related, myelofibrosis, and aplastic anemia. It's a straightforward question, right? Erythropoietin, the source is from liver or kidney. Predominantly kidney, little bit of them comes from the liver, right? So if kidney fails, obviously erythropoietin will help in renal failure, right? That's the only place where erythropoietin can actually help. Please do remember, treatment of renal failure related or CKD related anemia is not just erythropoietin, it's erythropoietin along with iron. Generally, our population is considered to be iron deficient. If I give only erythropoietin and there is no raw material of iron, bone marrow will proliferate, but I won't have a good number of RBCs or hemoglobin. It's always erythropoietin plus iron, which is very, very important. Great. Interstitial cells of the kidney secreted. The juxtaglomerular apparatus also secretes it. That's the main source of erythropoietin in an adult, right? Okay, perfect. Nothing much here. This came as a question. Just recall. Answer. What do you think is the next answer? Simple question again. See, INICET gives quite a good number of match the followings or select the right answer, multiple right answer. It keeps on varying every exam. The problem with this, and the good thing about that, the problem is if you're in a hurry, you tend to write the wrong answer. Good thing is they are very easily you can rule out and write the answer, right? Everyone must have ruled this out. BRCA2 prostate cancer, aren't done. P10 thyroid lesions, aren't done. STK11 and TP53 are something which are kind of abnormal. But I'm sure you must have known one thing what macrophage said. Mucosal neuroma is a finding of MEN syndrome, right? If we exactly say MEN2B, there's a finding seen in MEN2B. So in MEN2B syndrome, I don't have P53 mutation, which is red proto-oncogene mutation, right? I'm writing proto-oncogene specifically because this is one of the rarest syndromes which can be involved with proto-oncogene, right? So mucosal neuroma is a finding of MEN2B where I see red proto-oncogene and I don't see TP53. And this also might look something like odd because generally when we read STK11, that's what I said that INICET tests the core understanding of a topic. STK11, Peutz Jeghers. Everyone in this world knows that, right? STK11 or other name is LKB1. Here you have Peutz Jeghers syndrome. Everyone knows Peutz Jeghers syndrome. Everyone knows colonic polyps, colonic tumors. But most of you stop reading after that because we wanted to rush it up. There are multiple other things Peutz Jeghers syndrome causes. It's a Peutz Jeghers syndrome, not just colonic tumors, right? It increases the risk definitely of breast cancer. Something which no one should forget. It increases the risk of pancreatic cancer. This, if I am an examiner, I will ask pancreatic cancer because I think the risk of pancreatic cancer is close to 400 to 500 times or 40, 50 times. It's very high risk compared to a normal population. Very, very, very high risk. And by the way, pancreatic cancer is something which comes to the patients or the doctors notice only in stage 3 or 4. Very difficult to treat as well, right? So if I'm the examiner, I'll be more focused on this. It causes hematoma. It does cause breast cancer increases. It also causes pancreatic cancers. Don't just stick to the mucocutaneous pigmentation and colonic cancer, right? Okay. Yes, mucocutaneous pigmentation is there. The image, whatever you saw, holds true. But the most important thing is your other tumors as well. Fine. Perfect. Next question. A very simple one. I'm just going to talk about only one extra finding in this question, then it'll go off. Answer is simple. Clemmenstein-Wilson nodule, KW lesion, right? That's a finding. I hope you must have read this. Not typically seen in other glomerulonephritis, which means what is a finding which is specific for diabetic nephropathy? The answer is pretty simple. Clemmenstein-Wilson nodule. Others are also seen. See, GBM thickening is also seen in diabetes, but GBM thickening is also seen in membranous Goodpasture syndrome. Food process effacement can be seen in diabetes, but seen in other conditions also. Something which is very clear is this, right? The other question which I want to talk is what Brahma has asked for, right? What is Armani-Epstein lesion, right? See, Armani-Epstein lesion and Clemmenstein-Wilson lesion are the two lesions which are seen specifically in diabetic individuals. These are nothing but lesions not in glomerulus. These are seen in proximal convoluted tubules, first thing. These are resorption droplets of sugar which is stored as glycogen. Okay. Where in PCT, you will have a very clear storage of glycogen because in diabetes, there will be glycosidia. All of them will be absorbed, converted to glycogen and stored in the PCT. Clear vacuoles seen in PCT is an Armani-Epstein lesion. Since we are in this topic of glycogen, can anyone tell me what stain will this be positive for? This is nothing but you will see in microscopy as clear vacuoles. With glycogen over the period of time, great Ketana. It's PAs. Can anyone complete that? PAs is right, partly. Can anyone tell me the enzyme and its sensitivity? Because that tells me it is glycogen. Because PAs is positive for many things, right? pH positive, diastase sensitive. It's pH positive and sensitive to diastase digestion. That makes it proper glycogen accumulation because diastase resistant. We'll talk about that also. There are two places for an MCQ point of view. I want you to remember about pH positive, diastase resistant. Which of them are pH positive, diastase resistant? Any protein accumulation is pH positive, diastase resistant. Your alpha-1 antitrypsin deficiency liver is a classical finding. I'll give you one more clue. That disease also has the same pH positive, diastase resistance, but not protein. This presents with GI upset, diarrheas. This patient also might have neurological symptom, findings in eye disease, great Sanvi, findings in the heart, nodal defects, arrhythmias, Whipple's disease. Whipple's disease, here the macrophages which has the organism will be positive, pH positive, diastase resistant macrophages in the lamina propria of the wall because the organisms here are pH positive, diastase resistant. Okay. Please do remember there are two conditions where I'll have resistance. One is Whipple's, the other one is your protein accumulation and alpha-1 antitrypsin deficiencies, right? Great. Next. Simple one. Not going to spend much time here, but I'll give you other combinations. I want you to nail what is the syndrome. 24-year-old, DCIS, strong family history, mother died at 31. The first test I would look for is BRCA1. BRCA1 is seen up to 55% of familial cancers. Okay. BRCA2 is seen up to 35% of familial cancers. Both together comes to 90% of familial cancers, right? Okay. Okay. Yeah, it's Triformaviplia bacteria. Okay. This is the common one. Fine. So now I'll give you other combinations, permutation combinations. You tell me what cancer syndromes comes to your mind because once they ask this, there's a possibility they can ask the rest as well, right? Okay. Let's say patient with osteosarcoma plus a white eye reflex. You keep on telling what's the answer. I'll keep on writing the options. Patient with breast cancer. Okay. Patient with hamartoma in the intestine. Also, patient has a risk of pancreatic cancer. Starting with the easy ones so that you can pick it up easily. CNS gliomas, sarcoma, leukemia, your diagnosis. Patient with lobular CA of breast plus gastric carcinoma plus breast cancer. That's lobular CA of breast cancer plus gastric carcinoma. Patient with, let's say, colonic tumors, skin tumors, bone tumors. Is right. Retinoblastoma. Second is also easy. Peutz-Jeghers syndrome. Third one, great. Lee-Fromney syndrome. A combination of CNS, sarcoma, leukemia is classical for Lee-Fromney syndrome. Never forget it, right? This is nothing but your CDH1 inherited syndromes. Last one, colon, skin and bone. See, neurofibromatosis, I will not tell without having a neurofibroma. That should be the basic symptom for neurofibromatosis. So I mean, not think of neurofibromatosis for the third option. Great. APC related, Gardner. Okay. Same colon, but CNS tumors. What is the answer? APC related, but Turcot. Okay. So there are different tumors across the body, not just from pathology, right? You must have read a few of them in surgery, few in medicine, few in pediatrics, right? So these permutation combination should always be in the mind for you to pick up, okay, this could be the most likely thing. They'll be common. Don't go for the common. Here alone, I want you to remember the rare one so that you can easily find out, okay, what's the right answer, fine? Okay, the next one. What's the answer? Chidiakiashi, Wiskott-Aldrich, Bare lymphocyte, Job syndrome. What's the thing? It's a pretty easy one. It's a very complicated disease, but this question had come very, like maybe 4 5 years back in same AIIMS, where they gave an flow cytometry of bad lymphocyte and they asked you how to find out a bad lymphocyte syndrome, right? From that time, most of us know what is a bad lymphocyte syndrome. Bad lymphocyte syndrome is nothing but it's an inherited primary immunodeficiency with lymphocytes lacking the HLA complex or MHC complex, right? So here, the lymphocytes will lack your MHC HLA complex. Since MHC HLA complex is lacking, they will not be able to elicit a graft rejection, right? They'll not be able to elicit a graft rejection because I need MHC1 or a HLA. That mismatch only is going to cause graft rejection, right? Because of this lacking in bad lymphocyte syndrome, they don't react. They don't react against much against a graft. That is kind of helpful for the patient in order to survive the graft rejection, fine? Okay. Kirna, let's not go into the types of bad lymphocyte. Yes, there are two types of bad lymphocyte. MHC class 1 deficiency for type 1, class 2 deficiency for your BLS bad lymphocyte syndrome type 2, and a very severe form of combined deficiency also is there. Those are the types, but this level of understanding for bad lymphocyte itself is more than enough. Fine. Okay. Tell me the options. Like I want you to pair with A1, B2, something like that. There are 2 3 matches. Match the following is something which AIIMS loves a lot. Like I said earlier, easy questions but needs patience. It's simple, right? You're right, macrophage. Rabies, 2 negri bodies, right? The advantage of match the following is if even if you know 1 or 2, you can match it easily. Parkinson's, yeah, okay, maybe I may not know it, but multiple myeloma Dutcher body, I'll know it for sure, right? So Parkinson's is Levi body, and your malakoplakia is going to be Michaelis-Gutmann body. Malakoplakias come 2 3 times in an exam. Malakoplakia is commonly seen in bladder, but it can be seen in bone, it can be seen in skin, it can be seen throughout the body. The problem with malakoplakia is it's a problem of macrophage. It's primarily a macrophage dysfunction. The macrophage is not able to eat the organism. So every inflammation becomes chronic and it will not be able to eat it at all. Yes, macrophage. Okay. There's a macrophage dysfunction. So what happens? You have a macrophage, it's trying to eat, not able to eat, stays there, destroys, keeps on propagating, right? So what happens? All these cells slowly over the period of give it more time. So they'll kind of inside the macrophage, they'll kind of calcify. This calcified material inside the macrophage is called as a Michaelis-Gutmann body. It's a pure macrophage defect. Since a macrophage defect, you can have that in any part of the body. It's going to be chronic inflammation, originally described in bladder. You must have read in bladder. INICET had one question where they had a skin nodule with malakoplakia. Calcification inside a macrophage is diagnostic of Michaelis-Gutmann body, malakoplakia, right? Since we are in calcification, can anyone tell me stains for calcium? That's a very simple thing. We have 2 stains for calcium. One is your COSA, von COSA stain. The other is one alizarin red stain, right? Which you think is commonly used? Commonly used is von COSA. The specific stain by default is alizarin red. Because alizarin red stains elemental calcium, which means Ca2 plus. Von COSA requires salts. So they're not that specific, but they are very cheap and that's why they are more commonly used. Mohan, oil redo is for fat, right? Okay, not for this. Okay, perfect. Next question. I think this question, I'm not sure if in a recall it had an clinical history or not, but tell me what's the answer. A. Okay. Just only one question here. Let's see how many of you are able to answer this question. Why is it not Samoma body? Why is it not Samoma body? Corpora amylacea is nothing but seen in prostate. They are the secretions which is kind of accumulating inside the lumen of prostate. The most important thing, you can see actually the prostatic epithelium here, the gland here in the center you have it, right? Most important thing is they are pink in color. Why not Samoma? Samoma is calcification and calcifications are blue in color, right? How to differentiate Samoma from corpora if a history or a microscopic organ is not given, fine? Yes, you are absolutely right. Corpora arnacea is seen in pineal gland. That is also a calcification, okay? Okay, this is seen in pineal gland. That also is a calcification. So that also should be bluish in color, right? Corpora amylacea is nothing but secretions. Any secretion is protein rich. So protein secretions will always be pinkish in color. The clue will be the color, the lumen, and if the history says there's a prostate biopsy, what is the finding there? Obviously, I'm going to go for corpora amylacea, fine? Okay. In Lewy body is an intracellular accumulation. So it cannot be in the lumen. It cannot be this big. That's an eosinophilic inclusion. Like we saw, we can see them in your Parkinson's and Lewy body dementias and others, fine? Okay. Next match the following. A cube. What's the answer? It's a simple one. Medullary carcinoma thyroid. You can go for calcitonin. Hepatoblastoma. Can go for alpha fetoprotein. Choriocarcinoma. Beta HCG. Pheochromocytoma. Catecholamines, metanephrines, everything is going to be for pheochromocytoma, right? It's very simple, okay? These are tumor markers. Most of them may also be immunohistochemical marker, right? Since we are on the topic of tumor markers, I'll write a few more tumor markers. Tell me where you see them, okay? CA 19.9. I'll keep writing it. CA 15.3. I'm not going to write CA 125 because we already know CA 125. CA, where do you see them? Whatever comes to your mind, do comment, okay? Then, apart from hepatoblastoma, where else alpha fetoprotein can be elevated? AFP is alpha fetoprotein, okay? Then tell me any condition where you can see beta HCG elevation apart from your choriocarcinoma. Great. Pancreas, great. Breast cancer, CA, colon. Okay, I'll give a clue for CA. For CA, remember mucin, because CA is again non-specific. Any tumor mucin rich, colonic, gastric, pancreatic can have elevated CEA, right? So it can be colonic, it can be gastric, it can be pancreatic. It should be a mucin rich secretion, even ovarian, but it should be mucin rich, even cervical. If mucin is rich, it will be elevated. That's for CA, because CA, carcinoembryonic antigen, is a byproduct of mucin. Alpha fetoprotein, perfect. First is HCC. That's what I'll think of first. Age will tell me hepatoblastoma or HCC, right? In addition to that, your non-seminomatous germ cell tumor, like your yolk sac tumor, it will be classically elevated, right? Beta HCG, any molar pregnancy or any placental site tumors. Any placental site tumor, beta HCG will be elevated, right? Okay. Just one question, which is a very old terminology, but if an examiner who's going to be experienced asks, they might land up asking this, right? What do you guys think about the term hepatoma? What do you think this is? Is it benign? Is it malignant? What do you know about hepatoma? Whatever comes to your mind. This is a very old tumor. It's been removed from all the books. Even WHO says categorically don't use this because it causes confusion. Hepatoma was an older term for hepatocellular carcinoma. It is not benign. Okay. The primary reason why it was removed is, like you guys, both QTP and macrophage said, it's benign. Most of them will think of benign. Hepatoma is the older term for HCC. Hepatic adenoma is the benign tumor. We don't have the term hepatoma at all. If at all asked, please think it's malignant. Please remember it is malignant. Fine. Okay. Perfect. Next. What do you think is the answer? It's a simple question, right? Epithelial mesenchymal transition, the answer is twist and snail, right? So these are two answers. Twist and snail are the one which is going to help me in the epithelial mesenchymal transition, which is one of the important steps of metastasis. Okay, please do remember epithelial mesenchymal transition is also involved in a normal process of wound healing. It's also involved during embryogenesis. It's not just during your EMT, just during your metastasis alone. It's actually a normal phenomenon where cancer cells use the normal genes, my normal capacity, and change them to mesenchymal tissue. Tell me, why is this required? EMT is required for one important step. What is the purpose or use of EMT? The use of EMT is very, very simple. Only when a tissue becomes mesenchyme, the tissue or the cell can move. The moment it becomes mesenchymal tissue, it will acquire actin and myosin molecules so the cell can move. For metastasis to happen, the cell has to move. Your skin cannot move. No epithelium in my body is capable of moving. The only movement is muscle, mesenchyme. WBC, mesenchyme. Chemotaxis, right? Mesenchyme. Mesenchyme only will move, and for that mesenchyme, you will get actin, you will get myosin. That helps the cancer cells move from one step to another. So it's very, very, very essential for the cancer cells to have EMT to undergo metastasis, right? So can I say, if one of you guys in the future is going to crack the code to find a drug against twist or snail, or to find a vaccine which destroys these two, can I stop metastasis? Yes, no, maybe. What do you guys think? There is a possibility, right? Always there's a possibility, always there's scope. Hope one of you guys will crack that soon. Fine. The next question. What's the answer? Come on, don't see the purpose of me telling that you guys will discover something in the future is that's true. Some of you will definitely do it. INICET or NEET PG is not the goal, right? The goal is very big. This is my favorite disease. 30-year-old female weight loss cough with pleural effusion. I don't even want anything else. The first line is enough for me to suspect the disease. The first line, you have to think of TB. If you think of anything else, even if you get NEET PG first rank, I am not happy. First and the foremost thing, common thing has to be sorted out, TB. To add to it, I have lymphocyte predominant. Let's say I have one simple question, right? You must have heard about a test called as an ADA, right? Is it useful in tuberculosis? Yes, no, maybe. It's useful in tuberculosis, right? So let's say I'm telling pleural fluid analysis in this patient shows very low ADA. What will be a diagnosis? You must have read about ADA things in your pleural fluid. You must have done also during internship. Pleural fluid shows low ADA. What do you think is the diagnosis? Even then it's TB. I won't rule out TB at all. Even if pleural fluid is less ADA, let's say even zero ADA, which is not possible, even if it's zero ADA, I will think first of tuberculosis because of the history and lymphocytes. That's enough, right? So ADA, if it's elevated, my confidence in diagnosing TB is more stronger. If ADA is normal or reduced, doesn't make it not tuberculosis. Please do remember, it's always TB unless otherwise proved. Okay, so when it's TB in the lymph node, what I'll look for is necrotizing epithelioid giant cells with necrosis. What I'll think in case of your mediastinal lymph node aspirate, right? Sanvi has raised one more question. Sanvi said SCID. Why did she talk about SCID? Can anyone tell me that? Because that also came once in an exam. SCID What is the relation of SCID to ADA? SCID to ADA. Anyone? SCID to ADA? That's one variant of SCID where adenosine deaminase will be deficient, will be mutated. Okay. Can anyone tell me the inheritance of ADA SCID? This is one thing with autosomal recessive inheritance. This is what came in an AIIMS exam once. Please do remember. Most of the SCID are X-linked inheritance, right? Autosomal recessive inheritance SCID is ADA deficiency, right? Great. Perfect. Done. Read the question carefully and tell. What's the answer? Most of the SCID are X-linked recessive, but ADA deficiency SCID is autosomal recessive. What's a tumor first? The answer is, the question is simple, right? It's a tumor of the classical palisading, and there's a nerve. So most likely I'll think of a schwannoma, right? Arises from the cranial nerve, absolutely right. Varicobodocin in schwannoma, absolutely right. Can be seen in neurofibromatosis, absolutely right. This is not malignant or metastasis. It's not that frequent in a schwannoma, right? So diagnosis schwannoma. So once my diagnosis is sorted, rest everything is also clear. Once in INICET, a superb question came. They gave a history of a tumor. Listen to me carefully. I'll ask you the question. History of a tumor in the wrist, which is attached to the nerve. Biopsy of the tumor showed spindle-shaped cells, verrucate bodies. What is your diagnosis? Schwannoma, neurofibroma. What is the answer? Tumor in the wrist, attached to the nerve, epithelial spindle-shaped cells, verrucate bodies seen. What's the diagnosis? Schwannoma or a neurofibroma? Come on, what's the answer? See, INICET is good for this reason. They test the core understanding of the subject and not few memorizing the facts. What's the answer? Answer is perfect. Answer is schwannoma. Please remember, schwannoma comes from Schwann cells. Schwann cell is seen in every myelinated nerve fiber, not just cranial nerve. Even the tip of the finger, if you have myelinated thing, because Schwann cells myelinates my peripheral nervous system, right? You can have schwannomas anywhere, right? So schwannomas can be seen in periphery and also can be seen in cranial nerves. Remember that first. The moment you see microscopy, Antony A, Antony B, verrucate, it is schwannoma. Neurofibroma will not have these three, okay? So neurofibromas will have only spindle-shaped cells. In neurofibroma also can happen anywhere, periphery or in the center, okay? So neurofibroma, there'll be no Antony A, no Antony B, no verrucate bodies. The moment you see Antony A, Antony B, verrucate bodies, it is schwannoma unless 100%. It's not neurofibroma. Neurofibroma will have spindle-shaped cells. They will also have the same IHC positivity. Can anyone tell me what's the IHC for schwannoma? The same as the IHC for neurofibroma also. What do you guys think? The IHC for schwannoma, neurofibroma is a marker called as an S100. I will try to group things for you. S100 is a marker for most of the tumors which arise from embryologically from neural crust. Nerves, neural crust. Schwann cells, neural crust. Do you know any other cells in the epithelium which comes from neural crust? You read all the 19 subjects together for one goal. What's the other cell? Melanocytes. For melanoma, S100 is a marker. Okay. For schwannoma, S100 is a marker. For nerve tumors, S100 is a marker. So this is marker for neural crust origin, right? The tumor is from neural crust, that's all. So wherever neural crust origins I have, S100 will absolutely be positive for it. Fine? Perfect. Next, a very simple one. Okay. Autosomal recessive, cystic fibrosis, mitochondrial labors, X-linked recessive Duchenne's muscular dystrophy, trinucleated repeats, is spinomuscular atrophy, right? This is not that difficult. I am sure you must have solved it even if given like 30-50 seconds. That's all, right? What is important from this point of view is generally people tend to memorize dominant recessive disorders. Please don't try to do that. You will fail. The mnemonic of A, B, C, D, E, F, G, F is useless. It will not help in the real exam. I'll tell you clues for you to rule out. In an MCQ, I want you to be smart. I don't want you to memorize everything, right? So I'm going to tell a clue for dominant disorder, not for autosomal dominant. But most of the dominant disorders are autosomal dominant without doubt, right? So if a disease presents later in life, it's dominant, predominantly autosomal dominant, right? I'll ask you a simple question for this. ADPKD presents at what age? 40, 50 years. Though it's written AD, but it's dominant only. It cannot present early in life. Marfan syndrome doesn't present at birth. Abraham Lincoln had Marfan syndrome. It will be later in life only. Dominant. Okay, that's a clue for me, right? Presence later in life. Okay. Mutations involving structural proteins are dominant. Collagen, structural protein, right? Fibrillin, structural protein, right? Ankyrin, structural protein, dominant inheritance only. Okay. Diseases which are cancer syndromes. Almost every cancer syndrome is dominant. Neurofibromatosis, von Hippel-Lindau, tuberous sclerosis, BRCA1, BRCA2, any cancer syndrome. Adenomatous polyposis coli, your familial adenomatous polyposis, Gardner, your P10 hematomatous, Cowden, everything, Peutz-Jeghers, almost every cancer syndrome is dominant. Okay, presence later in life, mutations involving structural proteins dominant, cancer syndromes are dominant. Go with this rule set. If something is outside this rule set, memorize that. But within this rule set, please don't memorize. You will end up in a very bad place, right? Next is recessive. Again, I'm not going to help you to tell autosomal or X-linked. That is a bit difficult to categorize with rules. Okay, recessive, one, presence at birth, presence very early in life. ARPKD, very early in life, right? Almost every inborn error of metabolism, phenylketonuria, galactosemia, every inborn error of metabolism will be recessive. Okay, almost every enzyme deficiency will be recessive. G6PD, X-linked recessive, but still recessive, right? Has to be recessive. Every metabolic disorder has to be recessive. And one last but not the least clue, disease which has carrier state or trait. Sickle cell anemia has carrier or not? Yes. Thalassemia, yes, recessive. Dominant cannot have carrier state, right? So these are rules for dominant and recessive. Please use them, right? Okay. Fabry-Hunter is X-linked recessive. Everything else is autosomal recessive, right? It will still be recessive, that's all. There will be no exception for that. If you have an exception from this, memorize that. Don't read the rules, read the exceptions. And these are not my rules, these are Mendel's rules. Gregor Mendel, father of medical genetics. He will not go wrong. Okay, so memorizing few things has to be little bit. Sanvi, example for structural ones, your collagen, Ehlers-Danlos syndrome, fibrillin, Marfan syndrome, Ankyrin, hereditary spherocytosis, all these are structural proteins. They form structure of a cell or a tissue. Okay, Fragile X, see, there are few exceptions. Okay, Fragile X is a trinucleated repeat disorder and is an X-linked recessive inheritance. Exceptions, memorize. Otherwise, they do follow the rule set. Okay, done. Please don't memorize the mnemonics for dominant and recessive. If you have a friend, junior, tell them not to memorize. That's not the way we read medicine, right? Tell me next. This is a superb question which came in exam. Some questions really test the core knowledge of a student. Tell me what's the answer. Because till this exam, no one included in the table of vacuotinous HbA1c. After this, every one added HbA1c to the table. Previously, it used to be only hemoglobin and all those things. What's the answer? EDTA. Right, beautiful. See, again, it's about understanding the disease. If you think HbA1c as a test of diabetes, you will almost incline towards gray color vacuotinor, right? Because glucose estimation, gray color vacuotinor, sodium fluoride and everything. But here, it is not an estimation of glucose. It's estimation of hemoglobin. I'm running the test on hemoglobin, not on the glucose. It's a glycated hemoglobin. Now the question is simple. Which test or which anticoagulant is the best for hemoglobin estimation? Answer is simple, na? Hemoglobin estimation, I use EDTA. So for any byproducts of hemoglobin estimation, be it electrophoresis or be it anything, I'm going to use the same EDTA only. It won't change. But yes, you are right. Sodium fluoride is for transported sugar, not the hemoglobin sugar, right? It's a very simple way to remember it. Apply and read. It's very, very, very simple. The moment you stop applying, you lose everything, right? This is for glucose. For HbA1c, it's EDTA, okay? Next. It's just for a most common thing. We read about most common inherited bleeding disorder, von Willebrand disease. The most common inherited coagulopathy is factor V lead-in mutation. Because of this factor V mutation, the factor V, okay, becomes resistant to protein C and protein S. Protein C and protein S is the one which will destroy factor V and factor VIII and make them inactive. Because of this mutation, they will not be able to destroy by protein C protein S combination. So they always stay active. That triggers the clot formation. Do remember. Okay. Other three also will cause coagulopathy, but this is the commonest one for coagulopathy. Fine. Leiden is a place in Netherlands, I think. That's why they discovered it. So factor V Leiden mutation. Okay. Next. This is a new question. See, INICET throws bouncers. If the same bouncers come back again, you should not make a mistake. But if it's an older question, new bouncers is completely fine. Ignore that. The new intranuclear immunohistochemistry marker for neuroendocrine cells is INMSM1, which is insulinoma associated protein 1. This came once in an exam. If it comes back again, do remember it's insulinoma associated protein 1 against a bouncer. If it comes back, remember. If it is not going to come back, ignore it. That's it. One more table. Let's see if you can answer it. This is the shelf life of the products. Here, the difficult part might be granuloside. Right? Granuloside might be a difficult part because we don't use granulosides often in real life as an intern also. You must not use it. Rest of it, most of the time, you must have used it, right? Packed red blood cells, the maximum shelf life I can get is 42 days. Platelets with agitation, 5 days. This also came once in an exam, right? Without agitation, it is going to be 1 day or 24 hours. But generally, we will not keep platelet without agitation. It's with agitation only, right? Cryoprecipitate can be precipitated up to 1 year. If I thaw it, I'll have to use it at the earliest within 6 hours, right? After thawing, the half-life, the shelf life reduces a lot. And obviously, left one is granuloside, which is going to be for 24 hours, right? So that's the combination here. Your packed red blood cells of 42 days, SDP of 5 days, granulosides of 24 hours, and cryoprecipitate of 1 year. Okay, done. Perfect. Next. It's a very simple question. Read this properly. Which does not help me to differentiate. Arctic fire, आप बोलिए हिंदी में. I'll try to do communicate in Hindi because मेरे को हिंदी नहीं आता. Not so much. Okay, sorry for it. See, intact membrane helps me to differentiate, right? In necrosis, there'll be a breach in the basement membrane, and in apoptosis, there'll be an intact membrane. It helps me to differentiate them, right? Okay. Enzymatic degeneration helps me to differentiate them. The lipid change is nothing but an indirect explanation of the membrane damage, the myelin figures. Nothing but a membrane damage. I see them in necrosis, I don't see them in apoptosis. What will not help me to differentiate is whether it's pathological or not. Okay, if it's associated with an underlying pathology or not, because this also can be associated with an underlying pathology. This also can be associated with an underlying pathology. Though this is both physiological and pathological, this is physiological. See, the lipid change is different. Okay, the lipid change is different. Lipid change is nothing but an indirect thing. Okay, fine, perfect. The myelin figures, yes. Next, which of the following is not associated with G6PD deficiency? Yes, Tejas. Which of the following is not a feature of G6PD deficiency? G6PD is an X-linked recessive inheritance. Okay. So it is more commonly seen in men or women? Where do you think G6PD deficiency is more commonly seen when it's an X-linked recessive inheritance? It's obviously more commonly seen in men. It's not going to be equally affecting both men and women. Oxidative stress will increase the amount of G6PD. Absence of NADPH because of the enzyme defect. I am not going to have female more commonly or male more commonly, right? Because of the enzyme activity, we won't have this, and presence of Heinz body is diagnostic of G6PD deficiency, right? Few things about G6PD deficiency. One, it's always a trigger induced hemolysis. If there's a trigger, be it a drug, anti-malarial, or be it a fever, or be it a fevabins injection, trigger induced hemolysis. G6PD can cause both intra and extravascular lysis, but predominantly it's going to cause intravascular lysis. Do remember them, right? It's mostly intravascular hemolysis because that will be the presenting feature, but extravascular can also have it, right? Okay, the next, G6PD deficiencies in microscopy, there are two classical findings. One is bite cells, okay, the other one is Heinz body. Can anyone tell me which of these two will be seen in normal Leishman stain? Normal Leishman stain. That's our job. Don't worry about it. We'll take care of it. Which of these will be seen in normal Leishman stain? Bite cell or Heinz body? Bite cells are finding seen in Leishman stain. And to identify or see Heinz body, we need a new methylene blue stain. Okay, a new methylene blue stain will be useful in identifying a Heinz body, and bite cell will see Leishman stain, right? Perfect. So tell me, what do you think is the investigation of choice for G6PD deficiency? That we can actually extrapolate for most of the disease which comes under this category. The investigative choices, enzyme analysis. Please remember, if the problem is in the enzyme level, the best way to identify them is analyze the enzyme. So enzyme analysis, enzyme will be reduced or absent. Based on that, I can clearly say it's a G6PD deficiency, right? Perfect. Okay. The next question. Fine. The next one. 17-year-old diagnosed with Hodgkin's lymphoma. Which of the statement is, please read carefully, incorrect? Okay, Mohan says B is incorrect. Macrophage B, 2B, good. It's a B cell tumor. There's no doubt that it's B cell origin. To be exact, it's said to be crippled B cell because they don't actually have all the markers of a B cell from the germinal center. Crippled B cell from the germinal center is the exact origin of proposed origin of Hodgkin's lymphoma. Perfect. Valdez ring, extraintestinal stomach, intestine in most of the places, non-Hodgkin's lymphoma is more common rather than Hodgkin's lymphoma. Non-Hodgkin's lymphoma is more common in other places. Hodgkin is primarily to the lymph nodes, one group of lymph nodes, predominantly cervical. Nodulus sclerosis is the most common. Mediastinum can be involved. CD15 positivity, CD30 positive is definitely common, is positive in RS cells, classical RS cells, right? Now, I'm going to group them into two groups. One is classical RS cells. The other one is your NLPHL. That's your popcorn variant of an RS cell. I'm going to ask you about only one marker. Tell me what is the status of PAX5 in both of these. What will be the status of PAX5 in both of these? Status of PAX5 in both of these. Macrophage, the nodular in the world and India mixed cellularity, that's actually a kind of a wrong statistics. To be true, most of the Indian cancer registries also show that nodular sclerosis is more common in India as well. At least in that aspect, we'll become a developed country. PAX5, it is very important. Weakly positive in classical, it's positive only, but weakly positive in classical RSL and classical Hodgkin's lymphoma. Here, it has to be strongly positive. The intensity of positivity is very important. Again telling, see, PAX5 is a B cell marker. I told it's a crippled B cell. So it's not strongly positive, it's weakly positive in case of a classical Hodgkin's lymphoma, and an NLPHL is popcorn variant of Hodgkin's cell, it's strongly positive. Apart from that, you know that this is 15 positive, this is 30 positive, this is 20 positive, this is 45 positive, right? But PAX5 is common in both. Okay. Next. What's the answer? It's match the following. Match the followings are always easy, right? Familial adenomatous polyposis, APC, juvenile polyposis, SMAT4, tuberous sclerosis, TSC1, Peutz-Jeghers syndrome, STK11. STK11 or LKB1, right? This is not difficult at all. Just ask you one question here. This tumor, tell me which of these above conditions you will see them. Because these are very, very classical for this tumor. Whenever you see any of them, okay, cardiac rhabdomyoma, angiomyolipoma of the kidney, and your SEGA, subepithelial giant cell astrocytoma, right? All these are classical tumors of tuberous sclerosis. Okay, never forget. SEGA, any of these three, if I see, the first thing is do a tuberous sclerosis testing. Mostly it will be right. Right? Any TS1 or TS2, there are two genes in tuberous sclerosis, TS1 and TS2. Any one of them will definitely be positive in these. Fine, perfect, great. Okay, so I got only these many questions. I wanted to keep it short, 1.5 hours. So just a quick recap of the past 3-4 papers, bits and pieces taken and selected from them. We'll have, like I said in the start, a different session, hopefully close to INICET, with marathon on what to read, just a quick revision. If you have any doubts in between, ping me on Instagram. Let's see, hopefully you'll get through the INICET. Will not wait for NEET. Get through the INICET and give some space for your juniors for NEET. Fine. Any doubts, do let me know. If not, we'll call it a day. Thank you guys.